Great. So my name is Hussein Al-Safar, and today we are going to talk about an approach to pediatric endocrine emergencies. The outline of today's lecture will be focusing on some electrolytes, some hormonal abnormalities with disorders that could lead to an emergency that needs an intermediate intervention to save life. So endocrine emergencies can be a very complicated topic, but we will try to simplify it here. If you know what you are looking for, then you know how to act and to save life by correcting the disorder when you can. It includes some disorders of calcium, some disorders of glucose, some disorders of sodium, and adrenal plus thyroid disorders, right? So we will talk about, like, if the calcium is up or down, if the glucose is up or down, if the sodium is up or down, and what we do if the cortisol is insufficient or there is a thyroid storm, right? In this session today, I'll be focused on all these aspects, but I'm not going to speak about sodium in details because I believe the sodium is going to be covered by Dr. Vina from a nephrology point of view. Okay, so we'll talk about the calcium, we'll talk about glucose, hydrocortisone, and thyroxine, and these are the headings of our topics. Right, so we'll take you through the first case. A 5-month-old baby, boy, is normally fit and well. On that day, he was found sleepy, and that's very unusual. Mom reported that that's unusual for her son. Usually he's active in the morning time. And then he was difficult to rouse up. That increased Mom's worries. What is going on here? There's no raised temperature. There's no preceding symptoms. He went to bed as normal the night before. So Mom called the emergency services, and paramedic thankfully arrived in 5 minutes. So part of their surveying, they checked the baby's glucose, and blood glucose was found 1.8 millimole per liter. That is low glucose. So there is a hypoglycemia here. Okay. So they gave a glucogel, which is a gel containing sugar, okay, to correct this hypoglycemia. It has been put in the mouth, that enhancing quick absorption while they are saving some time to put an IV access. And then the baby started coming around. Then they took the baby to emergency department, and blood glucose on arrival is 1.4 millimole per liter. So now you have an idea what we are talking about. It's a 5-month-old baby with hypoglycemia, and it was severe hypoglycemia that making the baby sleepy, difficult to arouse, and now we got confirmed hypoglycemia on arrival to emergency department. Before we go into discuss this case, I will just speak about hypoglycemia in general, revising some physiology, because that will help us to understand what is going on. How can I reach a diagnosis? How can I treat? And then we will talk about some pitfalls that people sometimes fall in, and that has got some medical legal aspects. So we need to be careful with that. Okay, so when the baby was inside Mom's womb during pregnancy, the glucose was going through the umbilical cord from Mom. Okay, and that glucose was saved in the baby's body as glycogen, and the glycogen was stored in the liver. That energy can be stored as fat or protein. When the baby is delivered and there is a sudden cut on the umbilical cord, so a sudden cut on the supply, then what happens is a sudden drop in baby's glucose, and that's normal, that's physiological. We are expecting this to happen, and that can drop to 2.5 millimole per liter. Okay, then this hypoglycemia, physiological hypoglycemia, is going to stimulate some counteracting mechanisms to overcome this. So glucagon will be released from the baby's body, the catecholamines will surge, the insulin production should be switched off, and glycogen stores, it should release the glycogen, and that to be forming a glucose through gluconeogenesis, or by glycogen lysis, and then the fatty acids is going to increase to make an alternative fuel to brain, which is the ketones. So maintenance of euglycemia, it happens through a complex interaction between plasma glucose, insulin level, and the counter-regulatory hormones. When we eat, when we have food, that will move the glucose from the stomach to the bloodstream, and then glucose from bloodstream to go inside the cells and need to get into the cell, need a key to open the doors of the cells to let the glucose inside, and that is the insulin. In euglycemic state, when you have enough food, you have enough glucose into your circulation, you don't need to break down your glycogen. You don't need to have a gluconeogenesis process, which is a very complicated process. You don't need a breaking down of fat to generate an alternative fuel. You don't need all of that. But what happens is, if there is a sudden drop, if there is a drop in the glucose, then the body will be alerted, okay? There will be an increasing process of forming glucose. Glycogen lysis is breaking down of glycogen. Forming a new glucose is gluconeogenesis. Lipolysis, breaking down of fatty acids. Forming ketones, okay? And the hormones that can play a role into this hypoglycemia: growth hormone, cortisol, glucagon, epinephrine. So when we have a decreased blood glucose concentration, that should switch off the insulin production from pancreatic beta cells. If there is insulin still being produced during the hypoglycemia, that is abnormal, okay? So no matter what, if we have hypoglycemia, the insulin production should be zero, almost. Should be switched off. The insulin secretion inhibited, if it's been inhibited, if that process happened as it should be happening, so that should allow activation of proteolysis. So from the protein, from muscles, that should go through reactions to help with the process of gluconeogenesis. And then that would be basically through Krebs cycle, through other reactions. Then markers here will be lactate, alanine, glutamine can be raised through this process. Okay, inhibition of insulin secretions will allow the lipolysis to happen, a breakdown of the fat tissue, the adipose tissue, that will form fatty acids and glycerol. There is another step here. It's the beta oxidation to help with this process to happen, and then ketogenesis leading to production of glucose and ketone bodies. So now if I have a problem here, so like I have an amino acid disorder, then I have a patient with low glucose and very high lactate. That will give me a clue. There's a defect here, a defect in the gluconeogenesis process, perhaps from the proteolysis. If, say, for example, I have very high insulin here, and very high insulin is stopping these processes from happening, is inhibiting them. I know that the problem here because of the hyperinsulinism. Say, for example, I have no ketones, but I have very high fatty acids, then problem here with beta oxidation. See how it's easy now to understand where is the pathology exactly? The fatty acids and glycerol, that just a focus into that, we have a marker to measure, which is the carnitine. So if the carnitine is very high, then I might think there is a beta oxidation disorder. Now, I would like you to give me an answer for this. I'm going to investigate this baby, taking you back to the case. He's 5 months old baby with hypoglycemia, confirmed in emergency department. I need to do hypoglycemia screen to find out what is the cause of this drop in the glucose. So when is appropriate to perform the hypoglycemia screen? Is it at any time, or at time of hypoglycemia, or you don't know? Can we have an answer to this question? So at time of hypoglycemia, most of you answering this. I'm just waiting. Someone said, I don't know. Well, that's fair to say. That's absolutely fine. We are learning here. It's a learning session. Someone said at any time can be done. Good. Can we have more answers? Yes, perfect. Excellent. So we got a variety of answers here. right? We got about 60 answers so far, and majority are saying at time of hypoglycemia, and some of them are saying at any time, a few of you saying you don't know. But the right answer is, I'll just minimize the chat, it's actually at time of hypoglycemia. The reason behind that, you need to find out where is the problem exactly, okay? I took you through the process earlier. If the patient is not hypoglycemic, if blood glucose is normal, then you will not see the activation of those mechanisms, okay? So anytime, you may not find out the answer. You need to find out during the time of hypoglycemia. Hence, I'm emphasizing today the importance of doing the hypoglycemia screen at the time of hypoglycemia. It shouldn't, if you are very well organized and you know where you're keeping your stuff and you got everything, so you take your blood samples and then you treat the hypoglycemia. If you find difficulty with that, get one of your colleagues to help you. The hypoglycemia screen, including a number of these investigations. So you need a lab glucose sample to confirm that hypoglycemia that you just tested on bedside. Bedside ketones is very helpful test because that can help you to differentiate, is it ketotic hypoglycemia or non-ketotic hypoglycemia? If it's a ketotic hypoglycemia, then there's a ketones that will, you know, it's a little bit reassuring. I'm not saying you shouldn't intervene, you should not do anything, but a little bit reassuring because you have ketones here, and we know the ketones is alternative fuel to brain, okay? But the problem is, if you are dealing with non-ketotic hypoglycemia, so basically the risk is very high here for brain damage, okay? Because there's no glucose, there's no ketone, here you go. Therefore, the risk of brain damage is very high. You need to work on it immediately, okay, promptly. Right, bedside ketones, there is a link here for you if you want to read more about this, usefulness of bedside ketones testing and evaluation of children with hypoglycemia. That's what work that I did with my colleagues previously. Otherwise, if you don't have this facility, you can take 3-hydroxybutyrate free fatty acid samples, but the results will not be on the spot. It will take some time to come back, especially if your lab hasn't got the facility to run these tests. Therefore, they have to send it away, and that will take even longer time to have an answer what was the diagnosis at the time. But if you have the bedside ketones, basically using the strips, similar to glucose strips, perhaps on the same machine of glucometer that you use in your emergency department, and you can have an answer. You need to measure the insulin and C-peptide. As we said earlier, if there is any detectable insulin, that's abnormal when you have a true hypoglycemia. So that could be hyperinsulinism. You need to test what is the cortisol level, what's the growth hormone level, what is the lactate ammonia and the acyl-carnitine. Lactate ammonia will help you to differentiate and to find out a cause, could be related to proteolysis process. Acyl-carnitine, carnitine, whatever, could be due to fatty oxidation disorder. Amino acids, again, that will help you to learn more about the proteolysis process, urine reducing substances, and organic acids. Right. When you screen for tissue glucose, blood glucose through the capillary sample, and the glucose is less than 3 millimole per liter, you need to take a critical sample we just talked about. Then, if the patient is non-acidotic, you need to know what is the hydroxybutyrate. Perhaps you do this retrospectively when you got all the results together. Okay, so if the patient is having low hydroxybutyrate, low free fatty acids, then you think it could be hyperinsulinism. Whether the hyperinsulinism, more high insulin in the body, whether it's exogenous or endogenous, if the C-peptide is low but the insulin is high, that we're thinking that is exogenous hyperinsulinism, like if the patient was injected an insulin and that injected insulin caused the hypoglycemia. Or like cases of congenital hyperinsulinism, where the baby or child, usually presenting in young age, they will have high insulin, inappropriate high insulin C-peptide, and that is what happened here. When you have hypoglycemia, that process did not happen at the beta cells to stop, to switch off the insulin, and you have too much insulin production, and that could be the cause of hypoglycemia. Therefore, it's endogenous. Usually, it's due to genetic mutations, and that is what we call congenital hyperinsulinism. I hope it's clear so far. Now, if you have low beta hydroxybutyrate, but you have high free fatty acids, then we are dealing perhaps with fatty oxidation disorder, like we mentioned then. If the patient is acidotic with bicarb is low, and you have high lactate, then you are dealing with gluconeogenesis defect, including glycogen storage disease type 1 or ethanol ingestion. If the ketones are very high, then either you're dealing with ketotic hypoglycemia, which most of the time is idiopathic preschool age children, and could be associated with viral illnesses. It's very mild, benign condition, usually without any consequence. Or could be glycogen storage disease or cortisol deficiency. If the ACTH was high at the time of hypoglycemia, so perhaps you are dealing with primary adrenal disease. Treatment, because we said earlier, this is a condition, it's an emergency condition. You should not sit on hypoglycemia because there is brain damage. So you need to get IV access. You treat with 2 to 4 ml per kilogram of 10% dextrose over 4 to 6 minutes. You need to check the glucose in 15 minutes. If the glucose is still low, then perhaps you need to repeat the dextrose bolus. The pitfall here, sometimes people, they correct the hypoglycemia, but they forget to put the patient on maintenance, and there will be recurrence of hypoglycemia. So you should avoid this from happening. You treat the hypoglycemia, especially if it was severe in the case before, you put the patient on maintenance of 10% dextrose. You run it as 6 ml per kg per hour, which gives you about 10 milligram per kg per minute. If the patient remained unconscious, because you don't know which pathway you are dealing with at the moment, you haven't got all investigations back, so perhaps you are dealing with adrenal insufficiency, despite you treat the hypoglycemia, you need to give hydrocortisone in this case, okay? You can give it IV or intramuscularly, that's fine. But usually there are markers with hypoglycemia like hypertension, hyponatremia, could direct you towards the adrenal insufficiency, but not always. What about if you have no IV access? If you have no IV access, even you try for intraosseous, you can give intramuscular glucagon. And in extreme situations where would you like to buy a time, especially if it's confirmed or you know the patient is having congenital hyperinsulinism, for example, and he was on IV treatment and then the treatment stopped, so perhaps you can give the glucagon subcutaneously for some time until you secure an IV access. Pitfalls I mentioned earlier, like failure to connect patient on continuous infusion, failure to send the hypoglycemia investigations at the time, failure to check urine for toxicity. That could be another reason for the hypoglycemia. Right. Let's check the time. I think we need to speed up a little bit. So if we are dealing with patients with hyperglycemia, glucose is very high, then your fear and things that need to be ruled out is DKA. Is the patient in diabetic ketoacidosis or not? For diagnosis, you need hyperglycemia, glucose more than 11 millimole per liter, acidosis, pH less than 7.3, or bicarbonate less than 15. And then you need to have an evidence of ketosis, the ketonemia, the blood beta hydroxybutyrate is more than 3 millimole per liter. Normal is less than 0.6 millimole per liter. Again, we are talking about the blood ketones, which is measured as a bedside measurement. You have instant results. If you have no access to the bedside ketones, perhaps you need to measure the urinary ketones. If it's moderate to large ketonuria, that can be sufficient to diagnose patients with DKA. If it's just trace of ketones or mild ketonuria, perhaps your patient is not in ketoacidosis, especially if there's no acidosis. Treatment, fluid replacement should begin before starting insulin therapy, at least 60 minutes. So the patient, you need to expand the volume initially with crystalloids before you're starting the insulin. If you start insulin immediately, then that is not going to be good. Insulin therapy, the recommended dose as per the International Society of Pediatric and Adolescents Diabetes is PAD, is to start at 0.05 unit per kg per hour or 0.1 unit per kg per hour, at least 1 hour after starting fluid replacement therapy. It's the reference in the references list for you to have further reading It's very good guideline, actually, if you want to go through. If you don't have enough time to go through a detailed, which is about 24, 25 pages, you can check your local protocol, familiarize yourself with it before you work in the emergency department. Potassium, if the patient is hyperkalemic, so just postpone starting the potassium replacement therapy until urine output is documented, so the patient is micturating. Otherwise, you begin with 40 millimole potassium per liter or 20 millimole potassium in 500 ml, or less amount of potassium if the patient is receiving fluid at a rate of more than 10 ml per kg per hour. Bicarbonate usually is not recommended in patients with DKA to correct the acidosis unless it's unusually severe acidosis with pH less than 6.9 with evidence of compromised cardiac contractility. Warning signs and symptoms of cerebral edema. If while you're nursing the patient and looking after the patient and patients start having headache after beginning of treatment, so that should raise a suspicion, shouldn't be let go without action taken at the time. Or if there is a progressively worsening of the severe headache or severe headache is, persists. Now, if the patient is in a shock and you give the IV fluid boluses, then that could explain a slowdown of the heart rate. But if there is a slowing of heart rate which is not related to sleep or improved intravascular volume, that should raise your suspicion of raised intracranial pressure or cerebral edema. Change in neurological status, like patient become restlessness, irritable, increased drowsiness, confused, incontinent, that all these kind of change in behavioral and neurological status should raise your suspicion of cerebral edema. Specific neurological signs like cranial nerve pulses, that could happen as well. That is like say, for example, facial nerve pulse. Previously normal, well child, and then he came with DKA after he started the management. He had a deviation of the angle of mouth, for example. So that should raise your suspicion about cerebral edema. Raising blood pressure and decreased oxygen saturation suddenly, again, could be a cause for you to think. Right, now a question for you guys. How frequent to check the blood glucose? Hourly? Now you're talking about patients, you admitted the patient with DKA, you gave IV fluids, you start the insulin infusion, and how frequent you can check the blood glucose? I'm waiting for your answers. I'm still waiting. You still have time. 32 so far answered. Come on, guys. You're 105 in this classroom. So almost third answer so far. I would like to see more answers. Right, let's go through the answers. So far, 56 answered. So the answers are, majority are saying 1 hourly. Some of you saying 2 hourly, and the minority of you saying 3 hourly. I have about 5% of you saying I don't know. It's fine. Again, we are learning here. The right answer is, let's minimize this, and the right answer is, it's hourly. Yeah, it's a DKA. We should not sit down watching without taking actions. Okay, and things can happen, can deteriorate quickly. So you're starting with a certain level of glucose. Sometimes there's a sudden drop of glucose after you started the insulin infusion as well as the IV fluids that you started before, and you don't want this rapid drop of glucose to happen. Okay, so you need to take actions. So the right answer is hourly glucose monitoring. All right. Now, how frequent to monitor the neurological status? So like a Glasgow Coma scale, and then you go by the patient and check the patient, check the pupils, look what the patient is reacting or not. Is it hourly? Is it 2 hourly, 3 hourly, or you don't know? Waiting for your answers. 44 answered so far. I'm still waiting. Right, okay, so we have 54 answers so far, and the right answer is hourly again, right? So you need to check your glucose frequently. Most of you said, let me get that again. All right, okay, so the right answer is hourly, that you need to check the neuro observations. You need to do the neuro observations so frequently, because again, if the patient is showing signs of cerebral edema, you need to act promptly rather than leaving things aggravating and deteriorating, because there is a risk of mortality. So we shouldn't take the DKA as easy. All right, I've got the answers now. Majority of you saying is 2 hourly, and perhaps that's the wrong answer, basically. Some of you saying, I don't know, which is, again, that's fine. So I hope by the end of the sessions, so you learn, and then that is going to change your practice. Okay, let's move on. So this is from the ISPAD, the International Society of Pediatric Adolescents Diabetes Guideline, that I encourage all of you to go and visit. It's open access, you can access it. You just Google it, or you go through the link at the end of the slideshow, and then you access this guideline. So basically, you put the patient on continuous infusion. You start after the fluid started. Then these are critical observations: hourly blood glucose input, hourly fluid input and output, neurological states at least hourly, if not more frequent. Say, for example, in a certain situation, you have to do it every 15 minutes or every 30 minutes. So at least hourly. Electrolyte 2 hourly after starting IV fluid therapy, okay, because you need to check the electrolyte balance. You need to monitor the ECG for T wave changes as well. So these are things that people sometimes are not focusing on, but with increasing the awareness of the importance of that, people start doing it more. Okay. If the patient is still acidotic and is not improving, then you need to reevaluate the situation. Sometimes the fluid calculation is not accurate, the insulin delivery is not going through, additional resuscitation is required, or sepsis. So antibiotics need to be started, especially can be started from beginning if the patient is febrile. If blood glucose starts dropping quickly, more than 5 millimole per liter per hour, so you don't want this quick drop to happen. Or the blood glucose dropped from, say, for example, was 27, 28, whatever, start dropping over the hours, reaching a cutoff of 17, you need to change the bag of fluid. You need to add some dextrose into the fluid. Because if you leave it as it is, the patient is going to end up in hypoglycemia. Sometimes glucose drops, but the ketones still not dropping, and the acidosis still not improving. So you need to continue the insulin to switch off the ketosis, but you need to add some glucose into the fluids to avoid hypoglycemia from happening. And then you need to adjust for the sodium infusion to promote an increase in measured serum sodium. If the patient, we said, has got neurological deterioration and warning signs we mentioned earlier, so in this case, you need to manage the cerebral edema by giving mannitol or 3% hypertonic saline, adjust the IV fluid to maintain normal blood pressure but avoid overhydration. Senior staff should be called in this case. You need to move the patient to intensive care unit, and perhaps you consider cranial imaging after stabilizing the patient. Now, I think we covered the glucose quickly into this session. We have things to move on with. So let's talk about the calcium. Calcium disorders, either hypocalcemia or hypercalcemia. Hypocalcemia we're going to cover today in this topic, and in this talk. It can be classified into infancy or hypocalcemia of infancy or childhood hypocalcemia. Causes in infancy could be due to prematurity, due to premature parathyroid gland, or prematurity, therefore the baby didn't receive enough calcium from mom during that time, or there is a resistance of the parathyroid hormone in the kidneys due to prematurity, okay? Or due to birth asphyxia, where there's tissue damage and then there's gush of phosphate into the circulation, and that could be on expense of the calcium. Gestational diabetes, transient or permanent hypoparathyroidism, high milk phosphate load. Very rare we're seeing this these days because most of the babies are either breastfed or they haven't the proper formula, so you're not having a cow gate on day one, for example, which has got high phosphate, and that could lead to hypocalcemia. Hypomagnesemia can play a role, and hypomagnesemia can be part of a syndrome or on its own if mom didn't have enough magnesium stores in her body at time of pregnancy. Or the baby on parenteral nutrition and baby is not having adequate calcium amount, exchange transfusion, chronic alkalosis, acid-base imbalance that could alter the calcium status, or maternal hyperparathyroidism that mom is running high calcium that was suppressing the baby parathyroid gland, and then after disconnecting the baby from mom through cutting the umbilical cord, the baby's parathyroid gland still on sleep mode, like that happens here in transient as well, hypoparathyroidism. So it needs some time for the parathyroid gland to wake up. Childhood due to rickets, vitamin D deficiency, or the vitamin D dependent rickets, whether type 1 or type 2, chronic renal failure, again hypoparathyroidism, or pseudo hypoparathyroidism, which is GNAS mutation that could happen and affect the G protein activity. Revising some physiology quickly again. So if you have a drop in the calcium, that should stimulate the parathyroid gland to produce parathyroid hormone. You need to have a magnesium in adequate level to work, otherwise the parathyroid sensing is not to happen properly, and therefore you don't have the parathyroid hormone that you need. So in response to that hypoglycemia, parathyroid hormone will be released. That will have two actions: one on the bone to release calcium from bone through osteoclast and then bone resorption, and the other action is basically to activate vitamin D from 25 vitamin D to 125 vitamin D by 1 hydroxylation, and that happens usually at the level of the kidney. The active form of vitamin D will act on the kidneys and on the intestine to get more intestinal absorption of calcium and more reabsorption of calcium through the kidneys. And hopefully by these three organs, and as you see the calcium is coming from everywhere now, the calcium should be restored back to normal. Now, clinical approach to hypocalcemia, you need to have some history on the examination, whether the child is having inadequate intake of calcium, for example, growth chart, is the child growing or not, has the child got malabsorption problem, and that's why the calcium is not being absorbed properly, or vitamin D is not absorbed from food, or the patient is having liver or renal disease or nephrotic syndrome, or the patient on drugs that is blocking the calcium. Right, need to know what's the serum albumin, because if the albumin is low, that could give me a pseudo hypocalcemia. We'll go and see that. If the albumin is normal, you need to know whether the calcium loss in the urine happening or not. If the calcium has been lost in the urine, so that basically the depleting cause for the calcium in the body, and that could be familial hypercalciuric hypocalcemia or Infantile syndrome. We've got other markers that is being lost in urine as well. If the urinary calcium is low, appropriately low, because the calcium is low, so you should not lose any calcium in the urine, then you need to know what is the parathyroid hormone level. Parathyroid should respond to hypoglycemia, should be high, but if low parathyroid, then this is a hypoparathyroidism. usually associated with high phosphate, or could be hypomagnesemia, therefore the parathyroid was not stimulated as per the physiology explanation from previous slide. If the parathyroid is high, then we are dealing either with rickets, so that is appropriate compensation, the appropriate response from parathyroid gland to treat the hypoglycemia that we see in rickets, or in pseudo-hypoparathyroidism like in Albright osteodystrophy disorder. If the albumin is low, you need to know what is the ionized calcium. If the ionized calcium is low, then you go through this route, you end up with this differential diagnosis. If the ionized calcium is normal, then you are perhaps dealing with just pseudo-hypocalcemia, so don't worry about it. Take you through this case. A 3-day-old baby was brought to ER after an episode of generalized stiffening of body with uprolling of eyes for 2 minutes. So it seems to be that the child is having, this baby, 3 days old baby, is having a seizure. Yeah. Let's mark the things. So as a 3 days old baby, generalized stiffening of body. So we are talking about seizure here. He was active, has no history of fever, so it's unlikely to be sepsis here. Decreased activity or poor feeding before the episode. So none of those. Baby was fine, all of a sudden drop. He was born at full term, so he's not premature. Spontaneous vaginal delivery. He did not have any birth asphyxia, so that's, that didn't happen. There's no maternal history of diabetes, so there's no gestational diabetes or gestational, so didn't happen. There is no history of maternal hypercalcemia, so unlikely that a cause that is causing a baby to have hypoparathyroidism due to maternal hypercalcemia per se. Before or after, there's no family history. Dad is healthy. There's no history of hypocalcemia. He has a 5-year-old sibling who presented with delayed walking at 20 months of age. That's unusual. Okay, so could be there is some sort of rickets here. He was worked up and he was started on vitamin D. That's why I'm thinking it could be rickets, because he was treated with vitamin D, but that stopped after 6 months. Okay, so that could be a reason. His 7-year-old cousin presented with facial twitching. Okay, 7-year-old facial twitching and carpopedal spasm at 4 years of age. Okay, so usually the tetany is it can be a feature of hypocalcemia. Okay, and you know that features of hypocalcemia can be variable from person to other. It depends on the age group as well. So for babies, the signs and symptoms of hypocalcemia can be very non-specific. The child could be having, for example, jitterness, irritability, abnormal sounds of cry, like hoarseness of the voice. Could have apnea. Sometimes they come, and as well as seizures. In older children, you can do part of your examination to elicit if there's any presence of Schwostek's sign. For example, when you tap on the course of facial nerve, there will be ipsilateral twitching of the face. Or it could be trousseau sign. If you apply a pressure, the cuff of the sphygmomanometer, the patient can go slowly into carpal spasm. I hope I can demonstrate that. Okay. So the cousin has got carpopedal spasm, so signs of calcium tetany here at 4 years of age, investigated and started on treatment with vitamin D, which is continuing. So there's something significant in the family history. Now, if we go back into the list of infancy, hypocalcemia of infancy, so there's no prematurity, there's no asphyxia, no gestational, so we ruled out the other causes. So perhaps this transient or permanent hypoparathyroidism here, we need some investigations to confirm. Could be hypomagnesemia, unlikely to be parental nutrition here because there's nothing in the history suggestive of that. Physical examination, he did not have any dysmorphic features. He has normal cardiovascular as well as rest of systemic examination. The laboratory investigation. Now, serum calcium 1.6, that's low, that's a normal limit, okay? Ionized calcium is low. Phosphate is high, okay? Magnesium is normal, so it's not hypomagnesemia. Parathyroid hormone, here you go. That's very low, is undetectable parathyroid hormone. That shouldn't happen. So that is hypoparathyroidism, because if you have low calcium, the parathyroid should respond to that low calcium, should be high. So the normal level of parathyroid at this stage should be above 9 picomole per liter in response of this hypocalcemia. But that didn't happen. So that is hypoparathyroidism. Let's go through the list. Urine calcium to creatinine ratio, it's normal below 0.75, it's 0.45, so that's fine. The CBC is fine, white cell count is normal. Normal lymphocytic count of 4, and X-ray test showed normal thymic shadow. Does anyone know why we have these investigations here? What's important about the X-ray in this case? What's important of knowing this child is having normal white cell count, lymphocyte count? Any clue? Wow, fantastic, excellent. Amazing. You know, I know that I'm dealing with clever students. Pre-intern, sorry. You're nearly there. You're going to join us soon. Right, so yes, DiGeorge syndrome, 22q11 deletions, perhaps. Yes, that's excellent. Very good response. Fantastic. Right, so if we go back again through the pathway that we mentioned earlier, so urinary calcium, we said it's normal, so we're not dealing with this. Let's change the color of. Hold on a second. My pen. So it's not this way. We have a low normal basically. PTH was low, so we are dealing with this. Here we go. So we have hypoparathyroidism. It's not hypomagnesemia, so it's just hypoparathyroidism. That's your diagnosis. Okay, now this is a feature of another 5-month-old boy under regular follow-up in cardiology clinic due to a ventricular septal defect and failure to thrive on furosemide. He was admitted for a chest infection, started on antibiotics. You know, patients with cardiac lesions, they are prone to have more chest infections. So he was on antibiotics. He has micrognathia and short filtrum. The only child to his non-consanguineous parents, no family history of endocrine disorders or calcium problems. I got this picture from the internet through Wikipedia, so I have to disclose that. Laboratory investigations revealed, again, let's get the marker. So serum calcium is low, phosphate is slightly high, normal urea creatinine electrolyte. Can we make a diagnosis based on these results? What do you think? Is it possible? No, yes, exactly. Well done. It's impossible to make a diagnosis just based on this. We need further markers. Yeah, right. Okay, so we need further markers to decide on which cause of this hypocalcemia. So basically here, the albumin is 41, urine calcium creatinine. That was raised. So this child is losing calcium in the urine, but parathyroid, it says here normal. This is the pathway again. So what do you think? What's going on? Let's see your answers. You just need to think a little bit. So you got the pathway in front of you. You got low calcium, more calcium loss in the urine, and parathyroid with a normal. Answers, please. Hypercalciuric hypocalcemia, furosemide side effects, hypercalciuric hypocalcemia, or Fanconi. Good, right. Any further answers? No? Okay, fine. Let's go. DiGeorge, wow. Okay, fine. Let's go back. So patient was on furosemide. So no, that's fine. So, fine. Let's go by the first answer, one of the good answers. So patient is with being on furosemide. So that could make a little bit of confusion here. So if the patient on furosemide, so that would be a reason for the patient to lose the calcium through the urine. Okay, so that could be explaining the loss of the calcium into the urine, right? More striking here that the parathyroid, it's not normal. It's not normal. Okay, so that's the reason why I put this slide. So this is inappropriate parathyroid, normal parathyroid hormone level. Inappropriate. What does that mean? When you have patient with hypocalcemia, calcium is low, and the patient is coming with symptoms. then the parathyroid hormone should be high. Should be high. If it's low or normal, it is low, well, the parathyroid, if it's low, or should be saying here normal, it's inappropriate normal, shouldn't be normal. Okay, so that's we are dealing with either hypoparathyroidism or hypomagnesemia. Okay, so I hope this is clear now. Yeah. So you need to fantastic, clear. So we need to interpret the parathyroid hormone on the same time with the calcium. What is the calcium at that time? Okay. So for hypocalcemia, when the calcium is low, the parathyroid, if it's normal, if it's functioning, parathyroid should be high. That's the mechanism. Okay. That's the feedback, how it stimulates the parathyroid. Perfect. Very good. Right, and someone said DeGeorge. Yes, you're right. It's DeGeorge, especially with that facial features of the patient. It's already written there. Come on. Okay, that's fine. Just joking. Okay, acute management of hypocalcemia. You need to take initial diagnostic blood sample, as we mentioned earlier. You cannot diagnose based on just calcium. What is the underlying pathology? You need to correct the hypocalcemia by giving calcium gluconate over 5 to 10 minutes. So slow IV injection. It's not just like a quick push. And this is a dose, usually 0.5 ml per kg of 10% calcium gluconate. The reason, and you have to have a secure IV access because extravasation could lead to tissue necrosis, and you don't want to push it quickly because that could induce cardiac arrhythmias. So you need to be careful with that. Then you maintain the IV infusion of 10% calcium gluconate. You remember when we treated the hypoglycemia, we put the patient on maintenance. Again, we do this in here again to prevent recurrence of hypocalcemia. You need to figure out what's the reason, stabilize the patient first. These are the doses. If a patient has 1 month to 2 years, for example, you need to give 1 millimole per kg per day, and then you divide that dose over 24 hours to give the infusion rate per hour. Once symptoms are resolved, you change to oral preparation. So if a neonate, for example, here, you give 0.25 millimole per kg 6 hourly. Okay. And then if the patient is having hypoparathyroidism, like we mentioned earlier, and we revive the physiology, then if you just give them vitamin D, perhaps that is not going to be of so much benefit because the lack of parathyroid makes the hydroxylation process in kidney not happening. Therefore, the active vitamin D level will be low in the patients with hypoparathyroidism. So you need to give them the active form of vitamin D. So you give them the hydroxylated form. You give the calcitriol, for example, or alpha-calcidol. Alpha-calcidol, we have a dose here for neonates, easy to be given once daily, 50 to 100 nanogram per kg. Calcitriol, recommended dose starting from 1 month of age. Case 4, I think we finished glucose, calcium, now we're moving to adrenal. A 13-year-old male presented with 10-day history of vomiting, hemodynamically stable. Okay. He has been seen 2 years previously with short stature. Sodium was normal at that time, 2 years ago. He had speech and language delay, learning difficulties, and was under investigation for autism. He was reported salt craving for years. That should raise a suspicion. Why is he salt craving for years? That's something need to be looked at in details. Biochemistry revealed sodium of 96 millimole per liter. I have to say, this is the lowest sodium that I've seen in my practical life. Okay. Right, so what are we dealing with? Examination, he's got normal heart rate, normal blood pressure, no clinical signs of dehydration, no signs of pigmentation, normal male genitalia, prepubertal stage. Now, in my mind, I have this kind of pathway if I'm dealing with hyponatremia. As I said earlier, I'm not going to do details in here because Dr. Vina is going to cover this erythroid disorder, but just quickly going through this. Hyponatremia, normal volumic, he said earlier from the stem of the question. We need to know what is these markers, the thyroid functions, cortisol, because it could be hypothyroidism, could be cortisol deficiency, or primary polydipsia if the patient is just drinking excessive amounts of water that dilute the sodium in the circulation. Or if the patient is oligouric, then you're thinking about SIDH, secretion inappropriate of antidiuretic hormone. We know from, well, you're still fresh perhaps more than me, let's see, the cholesterol pathway that is leading to pregnenolone, and then you go all this routes to through the adrenal cortex to end up with three pathways: the mineralocortical pathway, glucocorticoids pathway, and the androgens. I'm sure you remember that, yeah? Now, if we have, let me remove this now. Okay, so if we have a problem with 21 hydroxylase deficiency, for example, what happens? So this enzyme is not going to work. So what is going to happen? Basically, we will have a deficit in mineralocorticoid production, deficit in glucocorticoid production. And then what happens? There will be diversion of the traffic to go this route because these roads are blocked. So it'll be diversion, go through the other way, okay? So there'll be more androgens coming here. So if it's a female, it could be virilized female, okay? Like having clitoromegaly, for example, right? And as a result, the patient will be cortisol deficient, will be mineralocorticoid deficient, will be having hyponatremia, hyperkalemia, hypertension, all of this, yeah? Is it easy now? Understand it? And then when you come to investigate, you have patient with high 17-hydroxyprogesterone, high dehydroepiandrostenedione, and high testosterone. These are your markers because you have low cortisol, you have signs of hypoaldosteronism. Good? So far, so good? Okay. If we have a defect into, say, for example, which enzyme you want? The 11-beta hydroxylase. Basically, again, very similar picture to the previous one from the 21 hydroxylase. Again, you've got these two routes affected, but you have precursors here a little bit raised. But again, 17-hydroxy, which is easily measured, epiandrostenedione, and the testosterone will be raised. If we have a picture of 3-beta HSD deficiency, then you have defect on all these routes, okay? Right. Just before moving there, so we have perhaps adrenal insufficiency in the previous case. The scenario, instead of this patient who came with 10 years old, could be a 10 days old baby. 10 days old baby who had been lethargic, for example, if he's having salt losing crisis, due to the adrenal insufficiency with congenital adrenal hyperplasia, due to, for example, 21 hydroxylase deficiency, which is the most common cause of CAH. The presentation would be similar. So basically have hyponatremia, hyperkalemia, hypertension. Okay. So those patients with adrenal insufficiency need to be admitted to high dependency unit or intensive care unit admission with careful fluid balance. And significant hypovolemia, you're starting 0.9% sodium chloride and should be given to improve the circulation. Basically, the treatment here is hydrocortisone. You need to give IV or intramuscular hydrocortisone, and then fludrocortisone based on the electrolyte imbalance. Hypertonic 3% saline can be given as 0.1 ml per kg per minute for 2 hours, aiming to increase sodium concentration by 10 millimole per liter. Pitfalls here. You don't need to rapidly correct the hyponatremia because that could lead to lethal pontine myelolysis. Right, if you want to read about that case, it's already been written here by myself and colleagues. Severe hyponatremia with neurological involvement in child with adrenal insufficiency. You can Google it and you can find it. Case 5. Now we move into thyroid. I think we are approaching the end of. We have only 3 minutes. Case 5 is a 4 days old baby boy born at home. Mom has Graves' disease on antithyroid drugs. Baby was classified as high risk antenatally. Therefore, it was planned to check baby's thyroid function test on day 5 of life. Mom has brought the baby to emergency department with concerns about his breathing. He started breathing fast. Examination, he was tachycardic, tachypneic, with evidence of exophthalmos, weight loss. He lost the birth weight more than 10%. That's significant. Diarrhea, mean arterial blood pressure 62 millimeter mercury. That's the thyroid functions. TSH is suppressed, free T4 is high. What are you gonna do? So basically, patients in such cases need to be admitted. You start in propranolol at these doses, 250 to 750 microgram per kilogram 3 times daily orally. You need to monitor blood glucose, chloral hydrate to sedate and making the baby settling because the patient would be irritable. and you start in carbamazole, 250 microgram per kg, TDS orally. In severe cases, sometimes they give prednisolone to inhibit the conversion of T4 to T3 and thyroid hormone secretion. The potential pitfalls, inadequate history taken. So patients, sometimes the people, they rush themselves and thinking, oh, this is sepsis, we need to screen for sepsis, start antibiotics and sit down. That's fine to start antibiotics for presumed sepsis based on the previous history, but it's crucial to take history, maternal history, what medication mom was taking during pregnancy, because you can mistake that. You're thinking that could be neonatal abstinence syndrome here that you are dealing with. Like you're thinking that mom was on drugs during pregnancy, and then the baby is just having withdrawal symptoms, which is not the case. Okay, so history taking is very important. When you deal with neonates, always take a history, full history. How was the pregnancy? How was the scans? Whether mom on any medications during pregnancy? If there any antenatal care plan, any plans for the delivery of the baby, you need to get all these details. Here are your references if you'd like to have further reading, and I would be grateful if you do this kind of survey monkey for me to get your feedback. So either by your smartphone scanning this what's it called, the code, or if you type this on your address bar, www.surveymonkey.com /r/ just like calcium, that's fine. And if you give me your feedback, that would be much appreciated. Okay, so now I have only 1 minute perhaps to take your questions. But you have my email should you have further questions. That's absolutely fine. Right, okay, right. So the HR code, yes. Oh, yes, that slipped my mind. Yes, the HR code. Please, if you do it, that's great. Very clear, thank you. That's fine. You are welcome, and I hope this session was enjoyable and you benefit from it in your practical life. Okay. Share this presentation because it has exercise about DKA. Will do, no problem. If a child has hypoglycemia and tolerating orally, can we give only candy? Well, you give everything, anything. If the patient is stable and asymptomatic, that's absolutely fine, but prefer to have something that has rapid absorption. If you give candy, you don't know how much is he going to absorb from that, the glucose from that candy. So perhaps you'll be ending up under treating. So better to have something as a professional. You should give something measurable and you know the effect of that. So I would say if the patient is tolerating oral fluids, and then we give like 15 grams of carbohydrate. So if you take a juice, for example, and you know that on the pack there's a 30 gram of that glucose in that juice, so perhaps you give half packet of that juice. Or if you have glucogel, then you give say, for example, half a tube. It depends on the age of the child, or the full tube, 15 grams. That's usually what we correct in the hypoglycemia with. Stay safe. All of you, please stay safe and keeping well. Thank you all for attending, and thank you very much for your feedback. In case of hypoglycemia, you mentioned we need to give maintenance fluids. So do we give dextrose? Yes, it's maintenance fluids of 10% dextrose, absolutely. What is the pathophysiology of hypocalcemia with exchange transfusion? That could be due to the phosphate overload that could happen with the exchange transfusion, and that would be on the expense of hypocalcemia. Not all slides are same. For the e-learning slides, can you apply this one? We'll try to do. For how long we keep child on active vitamin D in case of hypoparathyroidism? It will be very long time. It will perhaps for life. But good question. So if we're treating someone with hypoparathyroidism and we give active vitamin D, because we said earlier that they cannot convert the vitamin D to active vitamin D, so we're continuing with given active form, but we need to monitor for hypocalcemia. So those patients, you treat them, and then your monitor is just to get the calcium on low normal level, low normal, okay? So you don't want to have upper normal calcium, because that will be, there's a risk for this patient to develop hypercalciuria, and that could complicate into nephrocalcinosis and then chronic kidney disease and renal failure and all of that. So you should avoid this from happening. So we just treat with hypoparathyroidism with the active form of vitamin D. We sometimes give calcium, but rarely, and then you just maintain it on the lower normal calcium. Okay. Is there any need to manage patients on vitamin D? Yes, sometimes you give the vitamin D as well. It depends on the sun exposure and their diet, nutrition, and all of that, in addition to treatment, yes. Phosphate. What will happen with phosphate? Treating with phosphate, given phosphate. Phosphate, people are very rarely having phosphate deficiency, okay, because phosphate is available in most, if not all, type of food. So rarely you have a patient with phosphate deficiency. Okay, if you want to treat, yes, that's right. They get hyperphosphatemia if on vitamin D. Yes, because what happens here, hyperphosphatemia, is that happens when you're treating with vitamin D because you are suppressing the PTH basically. And the PTH is phosphatiuric, so that will lead to controlling the phosphate level. That should come down. If baby is unarousable, hypoglycemic, do we rush for glucagon injection? You can do, absolutely, you can do. Yeah, hypoglycemia is a serious condition, can leave neurological consequently. So if you have access to glucagon injections, yes, absolutely. If patient is unconscious, yes, yeah, absolutely. And basically with patients with congenital hyperinsulinism, for example, or diabetic patients, when we see them, we train them on glucagon, and then we discharge them on glucagon. So parents, they have glucagon injections at their home to deal with any kind of severe hypoglycemia. So if patients are on diabetic, and we said received too much insulin, and or he didn't eat enough amount of carbs, and he slept and then he became unconscious, and then they measured his glucose and found low, and he's unconscious, he's not responding, so they just crack on and give the IM glucagon injection. Similarly with patients with congenital hyperinsulinism, where they are prone to have hypoglycemia, and they are on medication to control that, but sometimes they end up with severe hypoglycemia as well, so they can give glucagon injection. Right, I think we have no more questions now, so good luck guys, and I wish you all the best, and we'll see you hopefully soon after this pandemic. It's going to go over. Keep well and safe, and thank you very much everyone, and good luck. Bye.